Welcome back to Nico's Perioperative. Before we wheel a patient back to the OR, we're always thinking about their hemoglobin levels, right?
Yeah.
But I have to admit, sometimes I think I've maybe underestimated the impact of even mild anemia.
Yeah, it's easy to do, especially when you're juggling, so many other factors in the perioperative setting. But this clinical focus review from Anesthesiology, I think it really drives home the point that anemia is a much bigger deal than a lot of us realize.
This review on perioperative anemia is pretty dense, but it's chock full of practical guidance on screening and diagnosis and management strategies that can really help us improve patient outcomes. And you're here to help me kind of unpack all of it.
Happy to dive in. Yeah, I think what's most striking is just how common anemia is in surgical patients, almost 1/3 present with it. And then the surgery itself can make things even worse.
1 in 3, that's way more than I would have guessed.
It is. And remember, we're not just talking about, severe anemia here. Even mild anemia has been linked to increased mortality and a higher risk of cardiac events after surgery. Plus, there's the whole issue of needing a transfusion and all the potential complications that can come with that.
Okay, so clearly this is something we need to be on top of. But with so many potential causes of anemia, where do we even begin?
Well, the review really strongly recommends screening all preoperative patients with the CBC, except, of course, for those undergoing very minor procedures. It's like the cornerstone of, effective anemia management.
Makes sense. Catch it early. But what happens when the CBC does flag anemia? What's the next step in the process?
That's where the testing algorithm that they outline in the review really comes in handy. They recommend further testing, including things like ferritin and iron studies, a reticulocyte count, and creatinine. And then if we suspect macrocytic anemia, we also need to check vitamin B12, folate, TSH, and liver function tests.
Got it. So basically a whole panel of tests to figure out, what the root cause is.
Exactly. The review actually advocates for what they call a reflexive anemia evaluation, meaning that if that initial CBC shows anemia, the lab automatically runs those additional tests, makes things a lot more efficient.
Yeah, less waiting around for more lab results. So let's say we've done the workup and we've diagnosed iron deficiency. That's where I think things can get a little bit tricky, right? Because the review makes this really clear distinction between iron deficiency and iron deficiency anemia.
Yeah, it is a really crucial distinction. I kind of think of it like this. Iron deficiency is like your car running low on gas. You can still drive for a while, but eventually you're going to run out of fuel and stall. Iron deficiency anemia is when you've completely run out of gas and you're stuck on the side of the road.
Okay, I like that analogy. So even if our patient's car isn't completely stalled out yet, meaning they have iron deficiency but not anemia, there's still cause for concern.
Absolutely. The review highlights that even without anemia, iron deficiency can have some, real impacts on health. Like we're talking about fatigue, brain fog, even an increased risk of heart problems down the line. And you remember that stat we mentioned earlier about the prevalence of iron deficiency? It's as high as 35 to 50%, even in patients who aren't anemic.
Wow. That's a wake-up call. So we can't just assume that if the hemoglobin is okay, everything is fine.
Yeah.
We really need to be taking a close look at those iron studies.
We do. And if we do find iron deficiency, it's not enough to just, throw some iron supplements at the problem. We have to really try to figure out what's causing it.
Yeah. Is it diet? Is it malabsorption? Blood loss? We need to be detectives here.
Exactly. And sometimes that means, calling in for backup gastroenterologists, hematologists, whoever can help us get to the bottom of things.
Speaking of reinforcements, let's talk about treatment options. The review spends a lot of time, comparing oral versus intravenous iron. What are some of the key takeaways there?
Well, oral iron is definitely, readily available. It's inexpensive. It's what we're all familiar with. But let's be honest, it does come with its share of downsides. Absorption can be really inconsistent, and those side effects like constipation and stomach upset can make it hard for patients to actually take it as prescribed. Plus, it just takes a while to replenish those iron stores that way, which, isn't ideal in the perioperative setting.
Yeah. So where does intravenous iron fit into all of this?
Intravenous iron has become increasingly popular, especially in the perioperative setting. And I think for good reason. It basically delivers that iron directly into the bloodstream, so it bypasses the whole absorption issue. That allows us to replenish iron stores much faster and more efficiently, and patients tend to tolerate it a lot better than oral iron.
Faster, better tolerated. Sounds like a win-win.
It often is. It's particularly valuable when we're talking about, that perioperative setting where we need to bump those hemoglobin levels up pretty quickly. But of course, there are always considerations with intravenous iron, like just the different formulations available.
Right. I've heard there are a few different options out there, each with its own pros and cons. What factors should we be thinking about when we're, trying to choose between those different formulations?
Cost is always a factor, of course, as is insurance coverage and formulary preferences. But I think from a clinical standpoint, we need to think about how quickly we need to replenish those iron stores and how many infusions the patient can realistically handle. Some formulations like iron sucrose often require multiple infusions over several weeks, which can be a real pain for patients and, logistically challenging for us.
So if we need to get those iron levels up quickly, we might opt for a formulation that can be given in a single larger dose, even if it's maybe a little bit more expensive up front.
Exactly.
Yeah.
It's all about weighing those trade-offs and finding the right fit for each individual patient.
Now, I know intravenous iron sometimes gets kind of a bad rap because of concerns about side effects, and the review actually does a good job of addressing those head on. Let's talk about those a little bit more after a quick break.
Sounds good. There's definitely more to unpack there. But one thing I do want to emphasize is that serious allergic reactions to intravenous iron are incredibly rare.
That's reassuring. It sounds like the benefits often outweigh the risks, especially when we're dealing with anemia in the perioperative setting. But we'll delve into all of that in more detail after the break. Stay with us. Welcome back to Nico's Perioperative. Before the break, we were talking about intravenous iron and some of the concerns that people have about using it, and I'm ready to kind of dig into those a little deeper.
Yeah, let's tackle the elephant in the room, right? That fear of allergic reactions, which is totally understandable. But thankfully, I think the newer formulations of IV iron have a much better safety profile than the older ones. Like, serious allergic reactions are extremely rare.
Okay, good to know.
Yeah.
But what about those, kind of minor reactions that I've heard about, the flushing, the chest tightness, that sort of thing?
Right. Those are definitely more common, but they're usually pretty mild and they tend to go away on their own. We can often manage those just by slowing down the infusion rate or maybe giving an antihistamine.
So basically nothing that the little pre-medication and close monitoring can't handle.
Yeah.
What about the risk of infection? I know that's been a concern with intravenous iron in the past.
Yeah, the review actually addresses that directly. And it basically says that while IV iron can promote bacterial growth in certain situations, the overall risk of infection is actually pretty low. The key is to avoid giving it to patients who have active infections, which, makes sense.
Yeah, it makes perfect sense. And there's one more side effect I wanted to ask about, hypophosphatemia. I've heard that can be a problem with ferric carboxymaltose, which is one of the newer IV iron formulations.
That's true. Ferric carboxymaltose can cause kind of a temporary drop in phosphate levels. So it's something we need to keep an eye on, especially if patients are getting multiple infusions. Usually it's not a big deal, but it's something to have on our radar.
Got it. So we've covered iron deficiency pretty thoroughly, but what about anemia of inflammation? The review describes it as a real challenge. Why is that?
Anemia of inflammation is tricky because it's not just about, low iron stores. It's about the body not being able to use the iron that it has effectively because of that chronic inflammation.
I always think of it like this. The iron is locked up in a vault, and the key to opening that vault is addressing that underlying inflammation.
Okay, I love that analogy. So even if we give these patients iron, it might not help much until we deal with, the root cause of the inflammation.
Exactly. Treating that underlying condition, whether it's rheumatoid arthritis or inflammatory bowel disease or even a chronic infection, that's really what's most important. Sometimes iron therapy can play a role, but it's not always going to be the answer. Now, speaking of iron therapy, the review also talks about those erythropoiesis-stimulating agents like EPO and alpha and the darbepoetin alpha. I remember those medications causing a bit of a stir a few years back when the FDA issued that black box warning about potential risks. Has anything changed on that front?
It has. Those initial concerns really came from studies that were done in patients with cancer and chronic kidney disease. And in those patients, long-term use of ESAs was linked to a higher risk of things like blood clots and tumor growth. But subsequent research, particularly in the surgical setting, has been much more reassuring.
So are ESAs safe to use in our perioperative patients then?
Well, the data seems to suggest that short-term use of ESAs in surgical patients is generally safe and doesn't seem to carry those same risks that we saw with long-term use in other patient populations.
That's good news. But it sounds like we still need to use them carefully and thoughtfully.
Absolutely. Individualized treatment is key. ESAs can be a really valuable tool, especially for patients who refuse blood transfusions for, religious reasons or personal beliefs.
Right. In those cases, the potential benefits might outweigh the risks, but it sounds like we need to have, those careful risk-benefit conversations with all of our patients when we're thinking about using ESAs.
We do. Shared decision-making is critical, as it is with all aspects of anemia management, really.
Now, before we move on, I want to touch briefly on vitamin B12 and folate deficiencies. They're mentioned in the review, but not as extensively as iron deficiency.
Right. But they're still important to consider, especially in patients who have macrocytic anemia. If we're seeing those big red blood cells on the CBC, we need to check those B12 and folate levels.
And if we find a deficiency, we just supplement, right?
Exactly. The route, whether it's oral or intramuscular, really depends on the severity of the deficiency and what's causing it. But generally, it's pretty straightforward to manage.
Okay, good to know. And now for the question that's probably on everyone's mind. What about blood transfusions? I don't think we can talk about anemia management without addressing that.
Absolutely. Blood transfusions are obviously a life-saving intervention, but we can't forget that they're not risk-free.
Yeah, there's always the risk of infection or an allergic reaction, circulatory overload. There's just a lot to consider.
And not to mention the logistical challenges and the costs that are associated with giving blood transfusions. That's why this review really pushes for that proactive anemia management. The goal is to get those hemoglobin levels up before surgery so the patient doesn't even need a transfusion.
Yeah, it's a much better approach than just waiting for things to get to that critical point and then reacting once the patient's already in the OR. Mm-hmm. So how do we actually put this proactive approach into practice? You know, the review offers some pretty concrete recommendations.
One of the most interesting suggestions, I think, is this idea of setting up a dedicated preoperative anemia clinic, or at least creating a defined pathway within the existing preoperative clinic to really streamline anemia management.
I like that idea. It's kind of like a one-stop shop for all things anemia.
Exactly. It would give us a way to, screen, diagnose, and treat anemia all in one place, which would help make sure that our patients are in tip-top shape before they ever set foot in the OR.
It's like having a checklist to make sure we've covered all of our bases. Mm-hmm. Did we check for bleeding? Are there any nutritional deficiencies? Is inflammation playing a role? It takes a lot of that guesswork out of it.
Exactly. And it lets us be more proactive in addressing the anemia before it becomes a major issue. Remember that statistic we talked about? Almost a third of surgical patients have anemia. We can't just wait for things to get really bad before we do something.
Right. We're anesthesiologists, not firefighters. Mm-hmm. We need to prevent the fire, not just put it out. And the review emphasizes that early intervention can really cut down on the number of blood transfusions that we need to give. And of course, fewer transfusions mean fewer risks for our patients.
And it means lower costs for the healthcare system as a whole. The review even dives into the economics of high V iron, which I know can be a real sticking point for some hospitals and health systems.
I've heard that argument before, that IV iron is too expensive. But the review kind of pushes back on that, doesn't it?
It does. It encourages us to think beyond that initial sticker price of the medication itself and really look at the total cost of care.
So, for example, iron sucrose might seem like the cheapest option at first, because it has the lowest acquisition cost. But it often requires, multiple infusions to really get the job done.
Right, which means multiple trips to the clinic, more nursing time, more inconvenience for the patient. When you factor in all of those costs, it might actually end up being more cost-effective in the long run to use a formulation that can be given in a single larger dose.
Even if that single dose has a higher price tag, it's all about looking at the big picture.
Exactly. And let's not forget about patient satisfaction, too. Who wants to spend hours at the infusion clinic getting poked and prodded when they can get it all done in one go?
Nobody. So as we wrap up this deep dive, what are the big takeaways for our listeners? What do we want them to walk away with today?
I think the biggest takeaway is that anemia is not something we can afford to ignore. It's a serious condition that can really impact our surgical patients.
We can't just focus on that hemoglobin number and assume everything else is fine. We need to be thinking about iron stores. Inflammation underlying causes the whole 9 yards.
Absolutely. And we need to be proactive in our management, using all of the tools that we have, oral iron, IV iron, ESAs, and even considering delaying elective surgery when it's appropriate to give us time to optimize those red blood cell levels.
It's really a shift in mindset, isn't it? From reactive to proactive, from treating the numbers to treating the whole patient.
It is, and I think it's a shift that can make a real difference in the lives of our patients.
Well said. I hope this deep dive has been as insightful for our listeners as it has been for me. It's definitely given me a lot to think about and some concrete steps that I can take back to my own practice.
Me too. It's a good reminder that even though we see anemia all the time, there's always more to learn, and there are always new ways to improve how we manage it.
Absolutely.
Yeah.
And that's what makes this feel so exciting, right? There's always something new to discover. So to all our fellow anesthesiologists out there, stay curious.